this intervention, one more please, would actually conduct behavioral research in each of these cities, specifically to improve the HIV prevention interventions in that city, and relatedly to conduct research about the nature and consequences of HIV infection among youth in high-risk situations in those cities. Next, please. In summary, I won't delineate all of the activities that were proposed by the technical working group on youth in high-risk situation. I think we can summarize them simply by saying the group suggested that we expand our research activities and that we expand our intervention activities specifically to reach this group. Perhaps the unrelated recommendation was, in addition to develop guidelines for CTRPN of youth, including youth in high-risk situations. Next slide. Our challenges then to address this particular population is to learn how we should best balance the resources that we provide for research with resources provided to implement intervention, how we can design and rapidly apply research specifically to improve those interventions, what we can do to most efficiently coordinate activities to address this population within CDC, among various federal agencies that address these youth, and certainly among public and private sector agencies that serve these young people. And then last but not least, how we can prevent HIV infection within a population whose other needs are oftentimes overwhelming.
Thank you very much, Lloyd. Can we have the lights, please? We have 3 more 10-minute presentations. Hang in there. You got a video and some very eye-catching slides from Dr. Bell. It'll wake you up. One of the challenges that this epidemic has provided is the need to work more and more closely with other of our PHS agencies, as well as a whole new group of constituents out there in the communities that we never have traditionally worked with before. Ron Baldessari, who's the new Deputy Director for CPS for HIV, is doing just that today. He is the one who presented the next target on men who have sex with men, but he is up working with HRSA on how to implement the Comprehensive AIDS Resource Emergency Act, or CARE bill. But we're fortunate to have a great deal of breadth within the program at CDC, and so Jacob Gayle, my Special Assistant for Minority Policy Coordination, is going to make that presentation.
Good morning. If I could have my first slide, please. Men who have sex with men comprise a highly heterogeneous population of individuals ranging from those who self-identify as being exclusively homosexual in regards to their sexual behaviors with others, to those who consider themselves to be virtually heterosexual but have incidental same-gender encounters, perhaps due, for instance, to environmental or economic constraints such as experiences in gender-specific institutions, or for individuals who trade sex for money or drugs. This category also includes males who perceive their true sexual attractions to be toward both females and males at varying ratios along a continuum, which sexuality researcher Alfred Kinsey identifies from 0 being exclusively heterosexual to 6 being exclusively heterosexual, with a range in between 1 through 5 representing varying shades of bisexuality. The term men who have sex with men also focuses more upon sexual behavior rather than personal sexual identification, philosophy, or categorization. It reminds us that not all men who are or have been homosexually active are gay identified, nor necessarily fit the stereotype that I think we've seen through this epidemic of being gay identified white middle-class males in highly urban settings. That's a very important point, I think, for researchers who are trying to study the population and to better understand how to develop prevention interventions. In fact, if you could show the second slide, and then we'll come back to the first one. Slide number 2, please. Thank you. This is a slide of data that was provided by John Curran and Ruth Berkelman in regards to the increase on annual AIDS incidence for men who have sex with men compared to the previous year. And you'll see on this, looking from 1987, comparing it to the year prior, 1986, that men who have sex with men who resided in LA, New York City, and San Francisco saw an increase of 22% from 86 to 87, 9% increase in 88 from the previous year, and in 89, a 2% increase. So we're seeing a decrease within the three cities mentioned earlier, and yet nevertheless still an increase in that population. The yellow bar identifies the metropolitan statistical areas with less than 1 million population, as well as rural populations. And you see that men who have sex with men who reside in those areas, again, are still increasing in terms of AIDS incidence, though we see an overall drop. The green bars represent all populations in this case, where we see it's gone from 46 to 18 to 14% respectively, according to the years that are identified on that slide. If we could go back to the first slide once again, I'd appreciate it. Thanks. Despite the perceived changes in the demographic depiction of the AIDS epidemic, men who have sex with men still constitute the single largest AIDS exposure category in the United States, representing approximately 60% of the individuals diagnosed with AIDS and reported to CDC since 1981. And with the reasonable possibility that as many as 500,000 of the HIV positive individuals in the states perhaps falling under that category, then we recognize that obviously prevention challenges and strategies call for long-term sustained behavioral changes. As I said before, the slide will show a little bit more of that. Despite the many advances in society relative to the recognition of human sexuality as a vital, normal aspect of human existence, there still exist stigmas and barriers to public support of sexuality research and education in general, and specifically in regards to homosexuality and people who practice homosexual behaviors. This clearly provides challenges to our efforts to develop prevention interventions which are based upon scientific understanding of populations and practices targeted. Adolescent males who have sex with males pose a potential threat of a new wave of the AIDS epidemic, very similar, I believe, to what we experienced earlier in the 80s in the United States. In fact, a San Francisco study indicated that younger males who have sex with men were more likely to engage in unprotected anal intercourse than men ages 30 and above who also have same-gender sex, possibly due to a misperception that the younger homosexually active men are not HIV positive, and because their cohort is probably not positive, that risk is non-existent. Nevertheless, it's important to recognize, of course, that the onset of same-sex behaviors can precede acceptance of one's own sexual orientation by several years. And also, in some of the research that has been conducted, we see that the expression of one's same-sex behavior may often be initiated in settings where older and more experienced sexual partners may be present. Hence, in fact, adolescents might be experiencing and increasing in riskful sexual behaviors, but not identifying the related risks. So our prevention attempts need to be not only to help these young people recognize the risk that they in fact are taking, but also to be able to understand the concepts of perception of mortality and the lack of invincibility. If we go to the third slide, in recognizing the challenges to our prevention efforts, I wanted to review some of the future program plans that have been identified as high priority for CDC relative to our work in preventing HIV transmission, morbidity, and mortality. The first of which is to develop, implement, and evaluate HIV prevention strategies specifically targeted to men who have sex with men, but men especially who don't necessarily identify themselves as being gay. Most of the activities that we've identified and we've accomplished to date have generally looked upon various outreach strategies and sites where self-identified gay men have attended or have been involved in, and the need, as you'll see listed here, to strengthen outreach to sites where high-risk behaviors take place, but not necessarily where people who are in those places are identified specifically by themselves as being gay. The need to also strengthen our outreach to female partners of bisexual men, thereby being able to provide prevention support not only in terms of the women, but also reaching bisexual men through their female sexual partners. Thirdly, I think it's very important that we look at all of these aspects of sexual behavior, and in this case, same-sex behavior, in the cultural, the racial and ethnic milieu in which we find the populations and in which the populations are that we're dealing with. The next slide will take us to the issue of the development, implementation, and evaluation of strategies specifically for young adult males, again, who are engaging in same-sex behaviors. Our hope is that we will continue to expand our work that we conduct with national, state, and local organizations, working with youth in general, and working with youth who are experiencing same-gender sexual behaviors in specific. It's very important, I think, also that we look at the whole aspect of HIV prevention education from a comprehensive perspective, involving not only education, but healthcare providers and also social service agencies. That the activities and the programs that we develop and continue to maintain involve not only information dissemination, but development of skills and training individuals to be able to conduct the skills necessary for risk reduction over long term. And then fourthly on here is the provision of technical assistance to HRSA, especially as it relates to their education and training centers for healthcare providers throughout the country. One more slide. Improving the sensitivity and specificity of our risk assessment methodologies, and this in particular for males who don't self-identify as being gay. The need to conduct methodologic research on the measurement of self-report or same-sex behaviors through self-report, to better ascertain how accurate self-report is in these situations, how reliable they can possibly be, and how in different populations, self-identified versus non-self-identified men, the differences in the results through self-report. The second deals with the conducting of anonymous, unlinked seroprevalence surveys in special settings, especially for men, again, who have sex with men but don't necessarily identify themselves as being gay or bisexual. Thirdly, providing support to a national sexual health and risk prevalence survey to continue to be able to provide to us the kind of scientific research that we need in the area of sexuality research. One last slide. And that deals with the evaluation of the impact of prevention outcomes in being able to help people access not only HIV prevention but also early intervention programs, dealing with the service provision to persons who do not normally avail themselves to prevention services, as well as being able to increase the access to partners of the indexed person, or being able to access the secondary and tertiary partners, etc. Initiating and sustaining behavioral change over long term, especially not only for those who are found to be HIV positive, but also those who are HIV negative. Understanding and learning more about the natural history of HIV infection to be able to provide a backdrop upon which we develop further prevention strategies. And finally, to prevent and delay the onset of secondary morbidity associated to HIV infection. Thanks.
Presentation will be made by Fred Kroger, who is going to talk about programs targeting the general public.
Thank you. I didn't realize this was going to be the penultimate, but we'll work at it. Could I have the first slide, please? First slide, please. First slide, please. Thank you. The Institute of Medicine in this book, The Future of Public Health, reminded us all of the importance of putting the word public, and not just the word, but the public, back into public health. It also reminded us that if we're dealing with behavior-related problems, that probably the most cost-effective way to do that is by efforts and strategies designed to shape and to influence and to affect the social environment in which those behaviors take place. Next slide, please. Jonathan Mann, who is the former director of the Global Program on AIDS, when he spoke here at CDC this last summer and also this last fall at Emory, took those same concepts and essentially said the same thing, is that we have an obligation to look at the social environment and to try to influence that through means of information education by making sure that the health services are there and that these are in fact integral to our ability to seize the prevention opportunities that are still in front of us. That involving the social environment, involving the public, is in fact integral to the prevention of HIV transmission. Next slide, please. How are we doing in that regard? Since 1987, the Centers for Disease Control has had a very extensive program of trying to educate the public. One of the measures that we use is the National Health Interview Survey, the Supplement on AIDS, which is a continuous tracking of adults' knowledge and attitudes toward HIV and toward AIDS. You'll see that the individual items on that have to do with how the disease is transmitted remain substantially high. But if you take a look at the bar, particularly on the left side, and you find out that about 70% of the adult population of this country knows the three means of transmission and believes those to be true. Next slide, please. I think more troublesome is what people believe or don't believe in terms of the casual forms of transmission. Again, some of the individual items are relatively high, and they are all improving. They're all going in the right direction. But still, only 27% of the adult public in this country understands and believes to be true that casual transmission doesn't happen. They're still afraid that an infected chef, for example, might pass the disease on to them. They're still afraid that if they worked along somebody who was infected and sneezed on them, that might cause transmission. So it's clear that we've made progress, but that we have a long ways to go. Next slide, please. I think perhaps more importantly is some data that we've received from Project HOPE, who, using the Lewis Harris polling agency, surveyed 3 countries, the adult population in 3 countries, the United States, United Kingdom, and France. One thing that we're looking at is what kind of exposure is happening in those countries to information about HIV and AIDS. We were pleased to note that if you look at the right-hand column, that the values with all of the means of getting information to people is highest in the United States of those 3 countries surveyed. Highest of all is the one you see in red, the 73.1, through TV ads. That in this country, that's the most common means of obtaining information about AIDS. And that our values, except for on posters and billboards, our values in this country are higher than for the other 2. Next slide, please. Part of that same survey, next slide, please, were questions about what changes have you made in response to this problem. Again, if you look at the right-hand column, that the changes that are reported by adults in this country are of a greater magnitude than in the other 2 countries. The one exception is on the adoption of condoms. There we only fare second best, which is very consistent with the nature of our national program, if you're familiar with that program. We in this country have not done a strong job of promoting use of condoms. We've talked about a lot of other things, and we've danced around prevention issues, but we have not really focused on condoms in this country to the extent that they have in other countries. Next slide, please. The Project HOPE people have, next slide, please. We need a different signal. Next slide, please. Am I speaking too soft? The conclusions of the Project HOPE people, I think, are again important to us. They say that television in this country, as well as in other countries, is a very, very important medium for reaching that public. Secondly, that exposure through multiple media does make a difference. People come out different when they get the information through a variety of ways, and the way that's most satisfactory to them, obviously, is an important part of that. And that thirdly, if we focus on specific behaviors in these campaigns, we can, in fact, influence those behaviors. Next slide, please. What does this mean in terms of where we go from here? I'd like to talk about 4 things. Number 1, I think we have an obligation to explore and to exploit the kind of technologies that are available to us. One of those that we've tried to use in our campaign is the technology of satellite means of putting together packages as well as live interviews so that we can take a story and see to it that that story is carried essentially the same way throughout the country. I'm going to show you just a very brief clip. Say it again. It's on the side. Oh, I see, they moved them. They made it right, that's good.
The fact is that most people think they are somehow immune to AIDS, but they are not at risk for HIV. The city wants to wipe out that myth. So does the federal government, which is kicking off a massive advertising campaign tomorrow to fight the spread of AIDS. The Centers for Disease Control developed this campaign, hoping it will get people to look at themselves and evaluate their risk of contracting the HIV infection, which develops into lethal AIDS. The second public service announcement is designed to explode this myth. Government officials believe the ads are hard-hitting, but realize it may take years before they really hit home.
I think to draw a point, it's only in recent time that our nation has gotten serious about the risk to health from smoking, and that has required people speaking explicitly and directly and over and over and over about the risks of smoking and health. And now,
Excuse me. That is a very small clip from an 11-minute news story that ran in Cleveland, Ohio at the time that we launched our last campaign. Taking PSAs, which have little tiny messages that are important about risk assessment, turn it into a big story told by us, told in the way we want that story told, and connected in that particular instance to the local health department in Cleveland talking about their local story. I think that we can exploit additional technologies like that better. A second thing that we're proposing to do is to really get more serious about applying epidemiologic science and evaluation science to this process of health communications. We've taken this blueprint that was given to us by the National Academy of Sciences and have tried to apply that to this process. One way that we're doing it is looking at our hotline a little bit more carefully and to see if that's telling anything about what people know and the effects of our campaign. The red values have to do with what have happened since we put the risk assessment, the need to perhaps get tested campaign into the mill. And what we're seeing is a substantial increase in the percentage of calls and the number of calls that result in a person asking for and receiving a referral for HIV testing. We're also taking a look, next slide please, we're taking a look at a variety of methodologies for assessing these campaigns. One that we've imported from Australia is continuous tracking, taking moment-in-time examinations of what people are doing or believing or knowing, doing this on a weekly flexible basis. Next slide, please. And laying this against events that are happening in the community, including public service advertising, to see the extent to which a campaign or a major event influence people's values in terms of their willingness or their plans to use condoms or whatever the other behavior or knowledge piece might be. Next slide, please. A third thing that we plan to do is we plan to switch from being a primary importer of technology and become an exporter. We've been borrowing from all kinds of people trying to bring to CDC the technologies of health communications. We're using our broadcast advertised report data to target communities in this country that don't seem to be paying much attention to HIV or to AIDS. We can identify those cities through this surveillance of TV public service announcement playing, ours as well as others, and see communities that seem to be ignoring the issue. We've run 15 community-based training programs, workshops, where we bring the media together with the local and state public health people along with the community service organizations so that they understand there's a local problem, there are local people that can help in that problem, and that there are ways that we can address this. Next slide, please. Next slide, please. Next slide, please. Next slide, please. Lastly, expanding our partnerships. That was a series of slides that if I had time would have gone into more detail. CDC has had some traditional partners. HIV, chronic disease, and other issues have caused us to expand that set of partners. We have expanded it with CBOs, the community-based organizations, as well as a number of national minority and ethnic population organizations. Our future, we're going to go after business, we're going to go after religious organizations, we're going after entertainment media. Why? These groups contribute over $114 billion a year, $10 billion of which goes into health. We think some of that ought to go into HIV. We think that these organizations are leaders and voices in our communities. We need to get them talking prevention. Thank you.
Lights, please. If Fred's presentation was the penultimate, then I guess David Bell's is the ultimate. David and Linda Martin are going to talk to us about programs targeting healthcare workers.
Thanks. Can I have the first slide, please? Over 6 million healthcare workers in the United States are potentially at risk of HIV infection due to occupational exposures to blood. I think this slide aptly illustrates the problem. This is the scene in a hospital emergency department after a trauma resuscitation. And can I have the next slide, please? This slide illustrates another aspect of the same problem, namely that exposures occur not only during patient care but also afterwards, in the sense that somebody has to clean this mess up. Next slide, please. Now, this is a summary of the major issues. We've learned a fair amount about these issues over the years, but there's still a lot to be done. Also, from time to time, new issues come up as well, as is illustrated by the last bullet on the slide. What is the potential risk to patients? Next slide, please. The CDC efforts consist of a number of activities, and the basic principle here is that we take data from our surveillance, epidemiologic, and laboratory studies and use them to develop guidelines and educational programs. Our first AIDS-related guidelines to protect healthcare workers were actually published in 1982, before the cause of AIDS was even known. Since then, we've published 11 additional guidelines for healthcare workers, drawing on data from our studies and those of others. Now, I'd like to focus on the surgical setting as a paradigm, a good example of how data from studies is used to develop preventive measures. Next slide, please. Surgeons, as you know, are in frequent contact with blood and also with sharp instruments, as you can see on the slide. They have exposures not only due to injuries with the sharp instruments, sharp bones, wires, and so on. Next slide, please. They also get splashed in the face, including eye splashes. Next slide, please. They get exposed when their gloves tear during surgery. Next slide. They also get blood soaking through the gowns. Next slide, please. Now, this year we've just completed a study. This was done by Dr. Jerry Tokars in our group. It was an observation study in 4 hospitals in high AIDS incidence areas where observers monitored operations. And as you can see, there were over 1,300 operations monitored in 5 specialties. Preliminary data indicate that individual surgeons got percutaneous injuries at a rate of about 1 in every 40 procedures. Next slide, please. Now, there were some interesting things seen about these injuries, including the distribution of them. It was noticed that most of the injuries occurred in the non-dominant hand. In fact, about a third occurred at the fingertip here, the distal phalanx of the index finger here. And that's because most of the injuries occurred while suturing and the surgeon was bringing the needle, presumably toward his or her fingertip there. This raises the question as to whether these injuries, or many of them, could be prevented by simple concepts such as thimbles. That may work sometimes, certainly not all times, because one would lose tactile sensation through the thimble, but perhaps based on data like this, special materials could be developed, or perhaps the thimble could be worn only during certain portions of the case. Another interesting observation, as I may have mentioned that a third of the injuries occurred while the surgeon was holding the tissue being sutured with his or her fingers while suturing. Next slide, please. This has led to renewed consideration of what's called a no-touch technique. This is an example of that. Here the surgeon is actually holding the tissue being sutured with an instrument as opposed to with the fingers. Once again, that might not be possible in every case, but it points in directions we can actually go toward determining, not just counting the needle sticks and saying, oh, well, they happened, but really trying to focus in on exactly how they happen and what exactly we can do to prevent them. Next slide, please. Now, another issue addressed in this subject was how often the needle, having stuck the surgeon, needle or other sharp object, recontacts the patient's open wound. This is another very timely example of a situation where data may be helpful in assessing the risk to patients. In this study, the preliminary results, the observers noted that there were 100 percutaneous injuries, and 29 of them, the sharp object recontacted the patient's open wound after injuring the healthcare worker. About 3/4 of them were suture needles. There were a variety of others as listed on this slide. Next slide, please. So in summary, major activities we see for the 90s include continuing surveillance and risk assessment, evaluation of preventive measures, including work practices, protective equipment, design of new devices and evaluating their effect on protection and on patient care. Post-exposure prophylaxis, just to say a second of a mention about that, we know from our surveillance that now about half of exposed healthcare workers in the United States in our projects are electing AZT post-exposure prophylaxis. This really translates into thousands, thousands of people, mostly women in childbearing age, who are taking this drug. We don't know if it works. We don't know about its toxicity. Clearly, there's additional information that we need to collect. So in general, this is kind of a summary of our activities, once again emphasizing the collection of data that then are directly used to develop guidelines. Thanks.
In the past, NIOSH activities have mainly focused in the agricultural and industrial setting, but many of the same principles can be applied to the hospital or healthcare worker setting. We've worked closely with OSHA to develop a rule for bloodborne pathogens, labor, as well as numerous centers within CDC, especially CID. Next slide. Workers are indeed at risk for occupational exposures to bloodborne pathogens. Good slide. There we go. Next slide. Many of these exposures can be prevented using traditional occupational health control strategies as shown here. Next slide. One aspect of job design would be the analysis of a task-risk relationship. Lorraine Day, an orthopedic surgeon you may all have seen, squaring off with Jim Curran on 60 Minutes about the potential of exposure of HIV to surgeons via the aerosolization of blood during the performance of orthopedic surgery. Although we don't have any epidemiologic evidence that this exists or occurs, it's important to define the problem, and a study has been initiated to characterize potential aerosols that are produced during these procedures. Next slide. It's possible, and we would all like to hope, that no risk will be identified, but if the data indicates that hazards are produced, then research efforts will be needed to eliminate or reduce the hazard to which these surgeons and other workers are exposed. Next slide. Personal protective equipment, such as gloves, are a mainstay for healthcare workers. Next slide. It's critical to evaluate the stability and effectiveness of gloves during use. A study has begun to validate a method to detect holes in gloves so that this method could then be used to assess the effect of such things as chemicals, body fluids, bloods, and other agents on the integrity of gloves and to develop recommendations for gloves use. In addition, as Dave mentioned, materials research is desperately needed to develop better glove material that will help eliminate needle sticks in surgery. Next slide. Healthcare workers' compliance to CDC's recommendations for universal precautions will reduce exposure, but data indicate that workers still do not comply in many areas. One particular area is in the use of recapping needles over and over again. Workers do not comply with these. Behavioral science scientists are needed to identify and assess reasons why healthcare workers don't comply with recommendations and to develop better educational tools to motivate them to comply. Next slide. NIOSH has been particularly involved in risk reduction and risk assessment for emergency response personnel, a group of workers who are located outside the hospital. They have some specific problems that are unique to them, such as most firefighters, who are also trained EMTs, go out on their job call in those heavy black coats that you would use to fight fires. An example was shown in the wreck on I-75, which showed firefighters going to a trauma scene with these big heavy coats on, which are really not appropriate for their job as EMTs, and they need special assistance. Next slide. In occupational health, one of the most important focuses is to engineer out the problem. Next slide. Since percutaneous injury has been documented as the primary route of occupational transmission, it's imperative to design devices that protect workers. Next slide. The market has been flooded with devices that claim to reduce or eliminate the possibility of needle sticks. Do they work? Are they necessary? What needs to be done? Next slide. Disposal of these sharps is another problem. I don't know if you noticed in Dave's slide, but down at the bottom there were a number of sharps on the floor. And if you have sharps containers, you need to find out if they work and what's being done. Next slide. The questions that are shown here are just part of the complex problem that needs to be addressed in the future regarding sharps containers and anti-needle stick devices. Next slide. Adequate engineering controls at reasonable cost must be given high priority so that workers will continue to provide their much-needed services to patients and the public without placing themselves at undue risk for occupational exposure. Thank you.
Lights, please. Thank you. There will be a chance for questions. Jim Curran is here if anyone wants to ask him what's happening with dentists in Florida or other things. As Wanda mentioned, there will be a meeting on the 21st and 22nd here on February 21st, 22nd down at the Hyatt Regency with consultants to talk about the implications of the risks of transmission during invasive procedures. I want to thank everyone who's helped with this. People who have comments and suggestions or questions about future AIDS rounds, AIDS updates, HIV updates. Wanda Jones is at 0904. Are there questions? Jim, do you want to say something?
Yesterday, the Institute of Medicine issued a report on the prevention of HIV infection in women and prevention of perinatal transmission. It was a report that came from a deliberation and workshop and panel that was sponsored by, co-sponsored by the National Institute of Child Health and Human Development and CDC, and in which many people here at CDC participated. The report, I think a few copies of the report arrived at CDC yesterday. It generally was consistent with the direction of our future recommendations and was, I think, very helpful in calling to describing the complexity of the issue, the importance of the availability of services for infected women, the importance of the concept of not testing children and indirectly mothers without the mother's consent. There had been a fairly strong push by members of the pediatric community to test kids at birth without their mother's consent, or sometimes in the absence of their mother's consent, to focus instead on providing much more widespread availability of voluntary testing and counseling for infected pregnant women. So the people at CDC and our public health community, particularly Larry Foster and Molly Coy, did a phenomenal job of working with the genetic defect type people and pediatricians who were on the panel who were involved in this report, and it'll be available soon. The second thing is that the AIDS clinical trial group at NIH had an announcement yesterday called the AIDS Clinical Trial Alert, once again from the National Institute of Child Health and Human Development, in which they announced that they would be stopping the trial of intravenous immunoglobulin for the prophylaxis of serious bacterial infections in symptomatic HIV-infected children. They had begun a trial a couple years ago of kids, mostly kids who had acquired the infection perinatally, who were randomized to intravenous immunoglobulin, I think 400 milligrams every month to prevent bacterial infections, and they showed that although there was no difference in overall mortality in these children, most of these children were immunocompromised or symptomatic, that there was about a 50% decline in the numbers of serious bacterial infections and a decline in hospitalization. So they stopped the blinding of the trial and hence decreed intravenous immunoglobulin as beneficial to kids with and without AIDS who had pediatric HIV. This is the first time that anyone has shown that anything is effective in infants, although certainly zidovudine and pneumocystis prophylaxis is widely used and likely to be effective. That's the only announcement. The MMWR is out today and announces, as the LA Times has, that there are 3 patients in the dental practice who acquired their HIV during the course of their dental care. The work that was done in the health department that I think gets credit in here, the Florida Health Department, as well as the county and local health departments, and here at CDC by a whole lot of people, including in our division, Carol Szelski and David Bell, Harold Jaffe, Ruth Berkelman, very importantly, Chin Yi-Oh and his staff in the molecular biology group of the laboratory. Tremendous amount of work and emotionally laden work by Larry Furman, Don Marianos, and others in the dental disease activity and CPS, and a lot of help from David Bell and Linda Martin and a lot of other people. Every time I mention people, I leave about 10 people out. Another voodoo doll is made of me. But anyway, it's been probably $1 million worth of staff work to do this. That's all.
Would you like to come to Mike, please, if you have a question?
Does the division have any activities, current activities, or future plans related to vaccines, or what role do you feel the division should play in either development or evaluation of AIDS vaccines?
We've had several conversations with the National Institute of Allergy and Infectious Diseases, probably the major actor in the world in the development and evaluation of HIV vaccines. Wayne Koff and of course Dale Lawrence, previously from CDC, are actively involved in these efforts. Our role in general could be described as a willingly able and willing to participate in the evaluation of vaccines at the level of moderate to large trials. I don't see CDC as having a major role in vaccine, or really any role in vaccine development unless you call, evaluation of immune response and pathogenesis vaccine development. It's certainly central to that. We're very much involved in looking at this immunologic response in mothers and the relationship of transmission to infants and things like that, but that's not really vaccine development. Our projects in Ivory Coast and Zaire, the one in Zaire is joint with NIH. The one in Ivory Coast will have a field visit by the NIH vaccine development team. Dr. Lawrence will be visiting there as a potential site for vaccine trials. The real issue is whether vaccine trials will get beyond the current immunogenicity stage. Will there be a large vaccine trial? And I think that whether we're involved with NIH or pharmaceutical industry or other countries or anybody else, the real issue is there anything with real promise of working? And we're not yet at the point to be able to answer that question.
You would agree, Jim, that the work that CID does in characterizing isolates of HIV from around the world is an important adjunct to the development of any vaccine. NIH has a collaborative agreement with CDC to do that kind of strain characterization. I would add that in CDC's history, we've had a long and proud tradition of involvement in vaccines, beginning perhaps with the polio vaccine field trials in the 50s. And I think that we would expect to play a role at some point, should there be large-scale vaccine trials. I want to introduce Dr. Valerie Setlow to the crowd here. Dr. Setlow is one of Jim Allen's principal assistants in the National AIDS Program Office in Washington. Valerie, we're glad to have you here. We look forward to getting a chance to show you more of our program. And are there any other questions?
Having not seen the MMWR article, but having read the LA Times article, there was some reference to the dental records being destroyed related to the 3 patients as far as related to their treatment. Could you comment, Jim, on that? And then I don't know if anybody's willing to make any sort of projections or any sense of direction that you think the recommendations are going to go in that are going to come out of the February 21st and 22nd meeting.
I don't know how you want me to comment about the records weren't destroyed in anticipation of the investigation or anything. The patient, the dentist closed his practice several months before patient A developed AIDS and had been closed for quite a period of time, and the records were no longer available. Doctors Furman and Marianos and many people down in Florida interviewed virtually all of the employees of the practice. The dentist himself had been interviewed before his death, and they were able to get and cross-validate information about the practices in the office, the infection control practices and things like that. The LA Times article implied that CDC had some information to suggest that this was a result of contaminated equipment. That is not the case. That was the major mistake in that article. In fact, we don't know precisely how it occurred. All we know is that 3 people have a similar viral strain to the dentist, and that they all had invasive procedures from the dentist. Many of them had many visits to the dentist. We know that occasionally the dentist stuck himself with a needle when he was administering anesthetics. We know the dentist, after 1987, according to everyone, occasionally wore gloves, did not always change those gloves. We don't really know how the transmission occurred. And that is not so unusual. That is just exactly how hepatitis B is known. I mean, the only way you really know is when you have a post-exposure follow-up, like we have with the needle stick studies. It's very difficult to reconstruct an event. It could be misleading when you read the MMWR to say that, well, there were no records of needle sticks. But I mean, after all, I mean, I've never known of a doctor or a patient that goes to the record and writes down, well, I stuck myself with a needle while I was doing that. I mean, it's a little bit crazy to think that that would happen.
At the outset, it was mentioned that we shouldn't expect increases in federal expenditures in the future for HIV, yet all of the speakers described new and enhanced program activities. It would suggest that there are some current activities that should be either reduced or eliminated. And I was wondering if you could describe what those might be.
Well, as you know, in the current budget climate in this country, our budget our national deficit continues to climb, and there are obviously a lot of things that need attention. A lot of good ideas have been identified in our technical working groups. Whether we are able to have any increase in funding remains to be seen. It looks very unlikely that we don't know until President Bush presents his budget to Congress in the latter part of this month, but it seems unlikely that we will have any increase or perhaps even any cost of living increase. So if we are to in fact capitalize on any of the new ideas and new priorities, we're going to have to look at our programs, each of our programs, and try to decide where we can restructure those programs, and perhaps also ask the states to help pick up some of that burden. Bill?
I just wanted to clarify that as well, and to indicate that a lot of the speakers were referring also to fiscal year 1991 activities, and there were some increases in fiscal year 1991. There was a major increase in funding for programs directed toward women and infants this year. There was an increase in programs directed toward youth in high-risk situations. There was increase in program activities relating to healthcare workers. So there were some increases, and you saw those reflected in what the speakers mentioned. Of course, there would have to be some modification of current programs versus future needs as we move along in this epidemic because of the plateauing of funding.
You've been very patient. It's almost 2 hours. We'll take one final question.
Just a brief comment and a question. Gary, you started out by saying that the minority health basically is part of all of the programs within what we've have presented here today. At the same time, however, we recognize that there are special characteristics and circumstances that require targeting a program specifically to those racial ethnic population. My question is, how are you planning to deal with the special circumstances of racial ethnic population within the broader programs?
Thanks for mentioning that. I would also mention that Dr. Reuben Warren, the Assistant Director for CDC for Minority Health, it's not quite the right title, but close, is going to be conducting a separate program review for Dr. Roper that will deal with all of the CDC programs that specifically target racial and ethnic populations. I don't have the opportunity, I think, the time to go into the details that your question really deserves, but let me just say that there are a number of programs that very specifically target racial and ethnic minority populations. Just to name a few, 33 national and regional groups that are directly funded to provide prevention programs for racial and ethnic minorities. We are directly funding nearly 100 community-based organizations. Over half of those represent minority populations. We're funding some 600 plus community-based organizations through our cooperative agreements with state and local governments, and roughly half of those are specifically targeting racial and ethnic minority populations. Jacob, you want to add anything to that?
Yeah, I was just going to say that when we look at the statistics that continue to increase, the fact that we already know almost a quarter of the cases to date have been within populations of color, that we see the trend increasing, if anything, and not decreasing, it means that everything that we talked about today is going to relate in some general or specific way to minority populations. Anywhere from the surveillance and epidemiologic studies that we're doing in women and infants, predominantly, obviously, in AIDS cases being women of color. Same thing in terms of men who have sex with men. We see that the risks that are increasing are more often in black males and other minority males. Same thing in terms of the other specific populations and groups that we looked at through the review today.
Thank you. Just a couple of closing comments. I want to really thank Peter Dropman for all the work that he's done over the last, I don't know how many years, Peter, in coordinating. 37. In bringing these periodic AIDS rounds together. Jim Curran's handout is at the door. I hope there's enough for those who want it. And I just want to say I am very proud to be a member of the CDC family, and I think it's a great organization, a great group of people. Thank you.